Hello and welcome to the Palliation lecture in the Psychosis series. This is Dr. Nicholas Hatcher, and in this presentation we will apply psychopharmacologic and psychotherapeutic principles in the management of psychosis. Here is a reminder of where we are in the series. Now that we have considered the various causes of psychosis, let's now turn our attention to treatment modalities. This lecture will emphasize the psychopharmacologic principles of psychosis treatment. Before we explore the details of psychosis management, let's first discuss some treatment-related statistics. 40 to 50% of patients with a first episode of schizophrenia will relapse within 2 years. Without ongoing antipsychotics after an initial episode, 70 to 80% have a subsequent episode within 12 months. Relapse prevention becomes a major clinical challenge, with greater than 80% relapsing within 5 years. Continuous use of antipsychotics reduced the 1-year relapse rate by 30%. Greater than 25% of individuals will have residual symptoms, and each successive admission to the hospital corresponds to a progressive decline in cognitive function. Unfortunately, antipsychotics have been implicated in brain tissue volume decreases and cerebral spinal fluid volume increases over time in several studies. Lieberman and colleagues followed patients treated with either olanzapine or Haldol for a first episode psychosis for 2 years. Patients treated with haloperidol, but not olanzapine, had worsening deficits in gray matter volumes that were already apparent after 12 weeks of treatment. It was unclear whether the relative volume reductions seen in the haloperidol-treated group reflected a disease process that was ameliorated by olanzapine but not haloperidol, a drug effect caused by haloperidol but not olanzapine, an increase in relative tissue volume related to the weight gain and metabolic effects associated with olanzapine, or a statistical artifact caused by sample attrition. Ho and colleagues have now demonstrated an association between antipsychotic treatment and brain volume reductions in patients ascertained with a first episode psychosis who were scanned longitudinally over an average of 7.2 years. Antipsychotics were associated with decreases in gray and white matter volumes, with higher doses resulting in greater decreases. Because of these findings, it is now recommended to use the lowest effective dose. I included this pathway on an individual slide to encourage reflection of the 3 hypothesized causes of psychosis on a biochemical level. Refer to the predisposition lecture emphasizing the neurobiology of psychosis for a review. All antipsychotics block D2 receptors. Second-generation antipsychotics also block serotonin receptors. I provided this table to summarize the relative function of the pathways that we have previously discussed and the result of dopamine and serotonin antagonism. Although we are especially concerned with dopamine and serotonin receptor antagonism, there is also varying affinity for other receptors. This table provides a brief summary of the effect of antipsychotics on a variety of receptors. We will go into each of these in a little more detail. The first of these receptors is IKR. This receptor is crucial for repolarization of cardiac action potentials, one of the many influencing the QT interval. Blockade reduces the movement of potassium out of the cell, prolonging the QT interval. This results in bradycardia. At some point, there's a compensatory shift in the cation influx to produce homeostasis. This shift, however, results in torsades de pointes. Torsades de pointes means circling around the point. As you can see in this rhythm strip, the QRS is essentially circling around the isoelectric line. This arrhythmia results in cardiac arrest, at which point the patient would require chest compressions, airway, and breathing support. Administration of IV magnesium is the treatment of choice. In order to prevent this arrhythmia, monitor the heart rate, as bradycardia is an early sign that the QT interval is prolonging. An EKG should be done if there is a concern, and a QTc greater than 500 milliseconds corresponds with a high risk. Addition of other medications that prolong the QT interval amplify this risk. The second is anti-adrenergic activity with blockade of alpha-1 receptors. This results in vasodilation and decreased systemic vascular resistance, or SVR. This then results in orthostatic hypotension, dizziness, and reflex tachycardia. Because of this, it is important to change position slowly and maintain hydration. The third is antihistaminergic activity with blockade of H1 receptors. This results in a general reduction of neurotransmission in the central nervous system, as well as blockade in the hypothalamus that impairs satiety. This then contributes to sedation, increased appetite, weight gain, and decreased cognitive and psychomotor function. It is important here to consider fall precautions as appropriate, monitor weight, and consider the effect that this may have on psychoeducation, therapy, and participation in the plan of care. The fourth is anticholinergic activity. I provided a few memory joggers that are commonly used to recall the effects of anticholinergic activity. The symptoms include the following: sedation, dizziness, confusion, and hallucinations, urinary retention, dry throat and mouth, constipation, blurry vision, dry eyes, feeling hot with decreased sweating, and tachycardia. Considering this, maintain appropriate fall precautions, monitor intake and output, utilize hard candies, sugar-free if diabetic, stool softeners, artificial tears, or saline eye drops. The fifth is dopaminergic activity. Blockade of D2 receptors does help with positive symptoms via the mesolimbic pathway, but will also influence the nigrostriatal pathway. The target of the nigrostriatal pathway is the dorsal striatum, which is essentially made up of the caudate and putamen. This area governs automatic movement. A special consideration of this is extrapyramidal symptoms. Extrapyramidal symptoms include a spectrum of abnormalities in automatic movement. I've provided a memory jogger with the relative time it takes to develop the symptom, along with a brief description. Acute dystonia involves pain and stiffness of the neck, as well as fixed postures. Akathisia involves restlessness. Parkinsonism involves the classic symptoms of Parkinson's disease, including tremor, rigidity, and bradykinesia. Tardive dyskinesia involves vermiform or worm-like movements of the tongue, as well as abnormal facial movements. Drug treatment is available for extrapyramidal symptoms. Here I provided a brief summary of what treatments would be used for individual extrapyramidal symptoms. Acute dystonia is best treated with diphenhydramine or benztropine. Akathisia is best treated with propranolol or lorazepam, but can also be treated with diphenhydramine or benztropine. Parkinsonism can be treated with amantadine, diphenhydramine, or benztropine. Tardive dyskinesia can be treated with valbenazine or deutetrabenazine. Benztropine and diphenhydramine both increase acetylcholine. Acetylcholine and dopamine are inversely proportional. Therefore, an increase in acetylcholine along the nigrostriatal pathway and in the dorsal striatum will result in a decrease in dopamine in that area, resulting in a reduction of extrapyramidal symptoms. The VMAT2 inhibitors, valbenazine and deutetrabenazine, block VMAT2, which is a receptor in synaptic vesicles that carry dopamine to the synapse. Blockade here will result in a reduction of dopamine entry into the synapse, and ultimately a reduction in extrapyramidal symptoms. This is particularly effective for tardive dyskinesia. The sixth is serotonergic activity. Second-generation antipsychotics, often abbreviated SGAs, have varying binding profiles for serotonin receptors. Most commonly, SGAs are 5-HT2A antagonists. It is also common for SGAs to be partial agonists of 5-HT1A receptors. Serotonin receptor antagonism in the nigrostriatal pathway contributes to less extrapyramidal symptoms compared with first-generation antipsychotics. This is primarily because dopamine and serotonin are inversely proportional. An important consideration, however, is the risk of metabolic syndrome. 5-HT2C receptor antagonism can result in weight gain, impaired glucose tolerance, dyslipidemia, and hypertension. I provided the criteria for metabolic syndrome as a reminder that individuals, especially on second-generation antipsychotics, should be monitored for metabolic syndrome. Neuroleptic malignant syndrome, or NMS, is a medical emergency that may occur consequent to antipsychotic use. This especially occurs in the context of rapid and large changes in dosing or multiple antipsychotic medication use. The syndrome is not necessarily related to the molecule itself. The mortality rate is around 15% for those who develop NMS and typically presents with fever, encephalopathy, vital sign instability, specifically autonomic instability with tachycardia and hypertension, elevated white blood cells and creatine kinase, and rigidity. When small changes are made, you don't see much NMS. If NMS does occur, it is recommended to give lorazepam 1 to 4 milligrams times 1 dose and consider dantrolene for hyperthermia. Supportive care measures should be implemented, including airway and breathing support and cooling blankets, among other things. Another important consideration is the black box warning included on most antipsychotics. There's an increased risk of death from cardiovascular causes in elderly patients treated with antipsychotics, especially if there is underlying dementia. A possible exception to this is pimavanserin, a new antipsychotic approved for psychosis in Parkinson's disease with promising results in the Alzheimer's population. Now let's compare the first and second generation antipsychotics. First generation antipsychotics preferentially block D2 receptors. On this slide, I have provided you with information on how dopamine is synthesized and terminated on a biochemical level. Here is a list of the currently available first-generation antipsychotics. These include chlorpromazine, haloperidol, fluphenazine, perfenazine, pimozide, loxapine, thioridazine, thiothexine, and trifluoperazine. This table summarizes the relative affinity of each antipsychotic to respective receptors that we have discussed. Second-generation antipsychotics block D2 receptors more selectively than first-generation antipsychotics. These antipsychotics may lessen negative symptoms more compared with first-generation antipsychotics. Additionally, they may also cause less cognitive blunting. Second-generation antipsychotics include aripiprazole, acinapine, brexpiprazole, cariprazine, clozapine, iloperidone, lumateperone, lorazepam, olanzapine, paliperidone, quetiapine, risperidone, and ziprasidone. This table summarizes the relative affinity of each second-generation antipsychotic to respective receptors that we have discussed. The CATIE trial is undoubtedly the most significant trial conducted on second-generation antipsychotics. In this trial, second-generation antipsychotics were compared based on a variety of factors. I have listed these for you in order to get an idea of factors that influence tolerance and adherence. In subsequent analyses, it was essentially determined that first-generation antipsychotics are equivalent in terms of effectiveness compared with second-generation antipsychotics. There are some studies that suggest that some antipsychotics have efficacy over others in terms of dopamine receptor occupancy, but it seems the evidence is pointing more towards equivalence in efficacy. The most appropriate approach now is likely an emphasis on side effect profile and tolerability over perceived efficacy. Several antipsychotics exist in a long-acting injectable form. These long-acting injections provide the added benefit of improved patient adherence. Here I provided a table with the long-acting injections along with the drug duration. Clozapine is a special second-generation antipsychotic with several considerations. The most important of which is that you must check a baseline complete blood count, or CBC, in order to ensure that white blood cells are greater than 3.5 and the absolute neutrophil count is greater than 2.0. This must be done within 7 days of starting clozapine. This also must be monitored on a frequent basis while on the medication. A baseline EKG is also required to ensure that the QTC is less than 500 milliseconds. Otherwise, it is best to reevaluate after the removal of other QTC prolonging medications. Clozapine is a medication that must be titrated slowly. It takes several weeks to get to the optimum dose. It is important to know, also, that if a patient stops clozapine for greater than 48 hours, it must be retitrated. This is done to reduce the risk of agranulocytosis. While on clozapine, it is recommended to check a CBC weekly for 6 weeks, then every 2 weeks for 6 months, then monthly times 6 months, then annually. If at any point the white blood cell count falls below 3.0, or the absolute neutrophil count drops below 1.0, then the medication must be stopped immediately. I will make a separate sub-lecture in order to discuss the full spectrum of clozapine considerations. Now let's put all of this together into some key management principles. With the first encounter with psychosis, try a second-generation antipsychotic first, with emphasis on tolerability over efficacy. Medications in this category include risperidone, aripiprazole, ziprasidone, and perhaps some of the newer antipsychotics, such as brexpiprazole or cariprazine. Then, if this has failed, emphasize efficacy over tolerability, with antipsychotics such as risperidone, olanzapine, haloperidol, perfenazine, etc. If 2 trials have been failed, or the patient presents with significant aggression or suicidality, consider clozapine. Because of the link between antipsychotics and brain-related changes that we discussed earlier, always consider the lowest possible dose. It is important that patients on antipsychotics, especially second generation, have the following monitored based on the table above: weight and BMI, waist circumference, blood pressure, fasting blood glucose, and lipids. The Abnormal Involuntary Movement Scale, abbreviated AIMS, is a tool that consists of 12 items rating involuntary movements of various areas of the patient's body. The scale is rated from 0, none, to 4, severe. Individuals at high risk for tardive dyskinesia should be evaluated every 6 months, and others should be monitored at least every 12 months. A positive AIMS examination is a score of 2 in 2 or more movements, or a score of 3 to 4 in a single movement. At this point, further evaluation and possible treatment with VMAT2 inhibitors should be considered. In addition to following up on antipsychotic tolerability, patients should be assessed for response to treatment. This can be done by rating symptoms on a scale of 0 to 10, whether symptoms are present or absent, or by the use of standardized scales. The scale with the most evidence-based support in the schizophrenia population is the Positive and Negative Symptom Scale. For downloadable content such as written notes, PowerPoint slides, and more related to this lecture series, please visit my website using the link below. You can also support my goal of continuing to provide new content through Patreon, where becoming a patron will provide you with access to downloadable content as I create new content. Thank you for your support. Here are my references for this presentation. Thank you for listening.